Hello, my name is Joe Poore and I am with National American University. I am taking the class Resource Design and Utilization for the Master's Degree Program in Nursing with an emphasis in Nursing Administration. This YouTube video will focus on healthcare waste in the United States. The United States has more healthcare waste than any other country. According to Shawnee et al., $1 trillion is wasted annually on healthcare. Shawnee et al. Also account that 14% of this waste is clinical waste that could be reduced by better prevention and more organizational processes such as best practice. Administrative complexity accounts for 9% and is the second biggest percentage according to Shawnee et al. This is where I will focus my healthcare waste problem. It should be noted that between 2009 and 2013, there was the slowest rise in healthcare cost noted, but this has since changed to higher rising costs in the last few years. The problem lies in how to reduce the cost. The Organization for Economic Cooperation and Development, OECD, suggests giving consumers better options and more incentives to lower costs. They also suggest providing payments to providers based on outcomes and efficiencies rather than patient volumes. In the past, self-regulation was used, but OECD suggests that the effectiveness of this is not fully assessed. The OECD suggests that 7% of waste is spent on staffing. This seems to be my biggest area of concern, which I will focus on. Currently, as a manager of the preoperative area, Phase 2 postoperative recovery area, and the endoscopy area, I have anywhere between 15 and 19 nurses a day to staff these three areas. My problem arises when there are 10 patients to be admitted in pre-op between 6 a.m. and 6:30 a.m. That means that I will need 10 nurses to admit these patients. I also have three patients to be admitted in the endoscopy area, plus I will need at least staffing for 2 endoscopy suites, which is a total of 4 to staff those areas. That brings my need by 7 a.m. to 14 nurses. I will also need staff to come in later to make sure that there is coverage for the post-op discharge area and to handle the load after surgery. In the past, there were many nurses who excelled in one area and tended to stay in that area, even though they should have been moving around to the other areas. Endoscopy in Phase 2 and pre-op, they're all the same nurses, they all work the same areas, and they should be rotating. Before I came along, that wasn't happening. It should also be noted that every nurse in these areas has a variable start time that's based upon patient needs. And this, again, was not being followed before I came along. The big waste in staffing came around 9 a.m. when a majority of the early cases were already admitted, and the rest of the day I had patients trickling in throughout the day. I don't need 10 pre-op nurses. Post-op patients are trickling in slowly after surgery, so I only need a few of them, and endoscopy is moving along with its own staff. I consistently had anywhere from 3 to 5 nurses sitting around after 9 to 10 a.m. waiting for other patients to trickle in. There was a lot of waste because there was little productivity in these nurses because they were needed early. We always had a lull during the day so they weren't needed, but then they were needed again at the end of the day to help post-op and discharge these patients. We just can't have that happen. The solution came from adjusting the staffing matrix and working with the pre-admission staff to form better workflow. Dumert suggests that in order to make a usable staffing grid, you must know the goals of the organization, the goals of the unit, finances, and customer satisfaction scores. When trying to figure out ways to understand the waste, it was discovered that pre-admissions nurses, the nurses that call the patients preoperatively to explain their preoperative education and tell them what time they should be at the hospital, were blanketing every patient with a 2 to 3 hour before procedural arrival, regardless of what procedure was being done. And they've been doing this because that's what was always being done. Doomer suggests that staffings that depend on other units should have a collaboration approach in making sure that both areas are running efficiently. Once we figured all this out, the solution to come up with was fairly easy. It was noticed that pre-admissions just picked a time based on what they were always trained on. So the solution was to have our nurses in pre-op, endoscopy, and phase 2, because again, they're all the same nurses working all the areas, help to train some of the pre-admissions nurses on what preoperative information was needed in order to effectively and efficiently admit these patients for surgery. With much of the emphasis being based on the procedure being done as a starting point to pinpoint what time the patient should arrive. A table was made for the pre-admissions nurses based on the case being performed. A communication tool was also produced by pre-admissions so they could let the preoperative area know special circumstances of why a patient might need to come early, such as the renal protocol or a patient having an X-ray or viral localization prior to breast surgery. The communication between pre-admissions and what was uncovered has really helped us reduce the issue of a lack of nurse productivity because of patient volume. Now the pre-admissions nurses use the communication sheet to help identify what time a patient needs to come in, and this is relayed to us so we can better staff each day. This has greatly increased efficiency because it has created a perpetual revolving door. So patients' arrival times are more staggered, so that when a nurse gets done with one admission, there's going to be another one shortly there behind, so it's more productive. And this has really helped so a lot of patients not arriving all at once. We have also been able to change some hours from 8-hour shifts to 10-hour shifts, which has really helped with both early and late case start times for better coverage throughout. One unintentional benefit was that while the pre-op nurses were working with the pre-admissions nurses, that these nurses that were helping pre-admissions effectively cross-trained into those pre-admissions positions. So if there's ever times that were slow, nurses in my area will go to pre-admissions and help them make preoperative phone calls. This has really helped out both areas because it increases my productivity when I don't need them, so I'm not paying them to sit around, and pre-admissions, it's helping them out because they've been paying a lot of overtime trying to catch up with phone calls at times, especially now during our busy time. Though the solution to the problem was fairly simple, it was not an easy task to accomplish. There was a lot of planning and collaboration in pulling this off. There was some pushback from older nurses who felt that they should be able to work in one specific area, and the heartache that they would actually have to uphold their standards of their job description and move around and have variable start times, because that was previously not being done. In the end, there was a lot of aha moments on both the preoperative discharge side and the pre-admission side on how to effectively take care of these patients more efficiently. And a lot of stuff was uncovered that was corrected. Productivity is now higher and waste has been reduced a great deal. Thank you for your time.